From now on, young adults will be able to stay on their parents' insurance until their 26th birthday. Children with pre-existing conditions will be able to readily obtain coverage. Once obtained, that coverage will remain in place regardless of how much care is required, and preventive services will be covered without copays or deductibles. With few exceptions, every citizen must obtain health insurance. That's good for everyone, since more people in the insurance pool spreads the risk and theoretically finances new coverage requirements to support appropriate payments for services when they are rendered. But given the current state of our insurance market, the question to be addressed is, what is the value of a new law requiring health insurance if people can't afford to buy that insurance? Beginning in 2014, individuals unable to afford insurance in the open market or through their employer will receive tax credits to help them pay for insurance premiums offered through what have been called state health insurance exchanges. Individuals and families who meet certain financial guidelines will be eligible for assistance with deductibles and co-payments, and premiums will be capped at about 10% of annual income. Today, if you are an employer, you are carefully examine what the changes will mean for your business and for your employees. And as individuals, many of you will be making coverage choices that will best meet the needs of you and your families. These are all changes that will have a positive impact on people's lives. These changes will help more people access the care they need at the right time and in the right setting, leading to a more productive and hopefully healthier America. Healthcare reform also will change the way Americans access healthcare services, which require providers to think differently about how we now deliver care. There are a great number of provisions in the law encouraging the establishment of pilot projects that will encourage healthcare delivery innovation. Under the legislation, an example of a new opportunity for innovation is called an accountable care organization. Accountable care organizations bring doctors, nurses, hospitals, and other healthcare providers together to share responsibility for keeping patients healthy. The goal of these new ACOs is to measurably improve the quality and satisfaction of a patient's care while reducing the cost of providing that care. Accountable care organizations generally are defined by four critical elements. First, they will be patient-centered and ensure better patient engagement, satisfaction, and self-accountability for their own health care. Second, the model is based on a primary care practice approach that offers 24 hours a day, 7 days a week care. Third, an ACO is expected to build a high-value network of providers who integrate and coordinate care to optimize patients' experiences as they move across a coordinated continuum of care. Fourth, ACOs are expected to enhance care through population health data management and have the ability to use information from many sources to optimize and promote wellness, clinical outcomes, and achieve economic successes. Overall, ACOs offer an opportunity to promote wellness, to improve integration, take care of the total health care needs of those who are enrolled, and promote joint accountability for care delivery between patients and their providers. University hospitals, like many health systems nationwide, is particularly well positioned to provide the comprehensive coordinated care required of accountable care organizations. In fact, we believe so strongly in this concept that we have already joined 18 other national health systems to plan for and create an accountable care organization in our respective delivery areas, and we have recently received national recognition for our early efforts in this regard. University Hospitals is well positioned to lead the implementation of an ACO due to the comprehensive nature of our integrated system and our ability to successfully include private practice and employed physicians in this new model. Our system includes nationally recognized specialty hospitals that Jan mentioned, including Rainbow Babies and Children's Hospital, and our new cancer hospital, which, when opened in the middle of 2011, will be the only freestanding cancer hospital in Northeast Ohio and will house the Ireland Cancer Center, a member of the Case Comprehensive Cancer Center, which is one of only 39 comprehensive cancer centers in the United States. Based on community need, we have expanded our reach and opened new ambulatory centers that include primary and specialty care, urgent care centers, on-site employee health clinics at corporate locations, and university hospitals' fast care retail clinics. In early 2011, we are opening the University Hospital's Ahuja Medical Center, which will provide adult inpatient, outpatient, and emergency services, outpatient medical and surgical pediatric services, and pediatric emergency services in a beautifully and efficiently designed, LEED-certified, state-of-the-art hospital with an open medical staff model, serving those patients who entrust us with their care. And we are making a $100 million investment in St. John Medical Center in Westlake, which we jointly own with the Sisters of Charity Health System, to better serve the needs of our patients and physicians on the West Side. We have a long history of working effectively with all of our physicians that now number almost 4,000 in our entire system. These physicians are in private practice or are in an employed model, either in University Hospitals Medical Group, which is our faculty practice plan, or our employed distributed physician delivery network called University Hospitals Medical Practices. And we look forward to working with all physicians in the future, just as we have in the past. And many of our caregivers and patients are already using our newly installed inpatient electronic medical record called UH-Care, which currently provides a single source of clinical information to patients, physicians, and caregivers for our inpatient services system-wide. In addition to access to health care, insurance, and new ways of accessing care, the health reform law intends to provide us with access to a variety of informational sources as a way of empowering all of us to make better lifestyle and health care choices. The law creates a National Prevention, Health Promotion, and Public Health Council tasked with creating a blueprint for improving America's health. Employers, too, are encouraged to offer wellness programs to employees, and grants will be available to encourage small employers to establish such programs. So what's missing from health care reform? Is the Patient Protection and Affordable Care Act all-encompassing? No, it is not, but nor can it be. Among all of the challenges and opportunities that the new law creates, many important issues have yet to be addressed. First, we must ensure that we have a strong workforce in place to deliver the care that this legislation now requires. You all have heard quite a lot about the shortage of nurses in the United States, and this shortage is real and is about to worsen as more nurses approach retirement age. What you've probably heard less about are the shortages in other healthcare professions. Nationally, our industry is lacking adequate numbers of nearly all allied health professionals: physical therapists, pharmacists, radiology technicians, those caring and highly skilled individuals who complete the clinical healthcare team, as well as shortages of highly specialized, non-clinical professionals as well. Nationally, we also are facing a severe shortage of primary care physicians, which could interfere with the healthcare reform goal of improving access to primary care and the wellness initiatives that I just described. Recently published reports predict a national shortfall of as many as 125,000 primary care physicians over the next 15 years. Only 30% of U.S. doctors practice primary care today, and the government estimates that 65 million people currently live in areas that are designated as having a shortage of primary care physicians. Today alone, we need almost 17,000 more primary care doctors to fill existing primary care coverage gaps nationwide. Nationally, we need to examine medical education and graduate medical education and find ways to incentivize more young physicians in training and retrain existing physicians to become primary care doctors while expanding the pool of physician assistants and highly skilled nurse practitioners. On an annual basis, approximately 26,000 new physicians complete their training at hospitals across the nation. And at university hospitals, we have almost 900 physicians in training, putting university hospitals in the top 5% of all graduate medical education training programs in the entire United States. And we will do our part to essentially match our training programs to the healthcare needs of the communities that we serve. The second issue that is not currently addressed under healthcare reform revolves around the important role of academic medical centers and their research missions. University Hospitals is the primary affiliate of Case Western Reserve University School of Medicine. Together, we spend over $230 million in funded research on the campus of the University Hospitals Case Medical Center and Case Western Reserve University, making us the largest center for biomedical research in the state of Ohio. As a nation, we must ensure that we have the resources to support basic science and clinical research, continuous investment in scientific inquiry, and educating future scientists as well. The third issue that is not addressed clearly in healthcare reform is scientific innovation. We must ensure that the United States retains our leadership position in providing the most advanced diagnostic and therapeutic modalities in the world. While it is estimated that new technology and its use account for 20 to 40% of the annual rise in healthcare spending in the United States, we must continue to lead the way.